Our next presenter is Dr. Timothy Leddy, who is an assistant clinical professor in the Department of Orthopedic Surgery at our medical school. He's also one of our upper extremity physicians here at UOA, and he'll be talking about sternoclavicular injury.
You've had a lot of anatomy. I'm going to touch on some things. I'm not going to beat that up too much. And some of the things that we talk about is just natural occurrences. We're normally teaching to medical students and residents, so there's a particular surgical bent to some of this. If you hear something you don't understand or you want to have a question, you don't have to wait until the end. You can stop me and ask me. I don't have a disclosure slide, but I don't have any disclosures. Oh, I do have a disclosure slide. Always makes me feel bad that I don't actually take money from industry. I feel like a sucker sometimes. All right, so the sternoclavicular joint is where your clavicle and your sternum meet. There is a capsuloligamentus complex of structures that help to stabilize that joint, and it's very hard to differentiate the joint capsule from the ligaments themselves. I like this slide. This is one of those things where nothing ever looks like it does in a drawing, but here they have things sort of dissected away for you. It just doesn't look like that in regular anatomy. But one of the things I do like about this slide is it kind of shows you how there's only really 50% of the articulation that's occurring here. Most people do have it riding up a little bit higher. So of the articular cartilage, there's only a little bit of that, and that kind of lends itself to wanting to subluxate or dislocate superiorly and anteriorly. And if you look at it, if you took it in cross section, you'd actually see that there's a tendency for the joint to be anteriorly verted, so that it's actually pretty hard for it to go posteriorly. So what impact does this have? We talked again, I'm not going to beat up what Dr. Gatt says, but the collarbone does help to support the articular connection of the arm to the axial skeleton. And it does transfer forces there, almost like one of these beams would on a crane. You see these extra support beams, and it's what enables us to do some of what we do with such great force and effort. The clavicle, however, is, let's say we sometimes call it an expendable bone. You can actually take the whole thing out. The arm still works. It's just not as functional as it should be. As a matter of fact, some children are born without clavicles. They can actually clap their shoulders together. But it is one of those things that provides an important structural component for strength and stability. It's obviously very important for any kind of weight bearing that you would do on your upper extremities because of that, and it's also important for most upper extremity athletic activities because of that. And so having even just a little bit of of injury, whether it's to the distal joint or the proximal joint, it's going to slow an athlete down. Rehabbing it can be relatively straightforward, and getting people back to sport is actually relatively easy based on their functional recovery, but it is somewhat dependent upon the amount of energy that went in to injure that in the first place. And that's in part what makes the difference between subluxations and dislocations in the SC joint. I mentioned here that many of these are sports-related injuries, but also a fairly high number of them are motor vehicle-related injuries. But at the end of the day, even though it looks like there's a lot of them, it really represents less than 3% of all traumatic injuries to joints in general. I'm not going to reread the stuff that I've already gone over, so forgive me for skipping through slides. And again, the osteology, Dr. Gatt already went through that, but there is an element of our articular disc here, as well as he mentioned the articular disc and the acromioclavicular joint also can be a potential source of pain. And again, it's much more fibrocartilage in that area as opposed to articular cartilage, but I think there's some argument there. So how do we diagnose these things? Typically there will be an event or a trauma. With anterior dislocations, there's going to be an obvious lump and a palpable deformity. Posterior dislocations, you really have to have a certain amount of clinical suspicion because they don't look that bad, but they're going to have other findings like dyspnea or dysphagia, not be able to swallow, not being able to speak properly. Breathing problems are usually not an issue, at least not acutely, but they can become an issue as swelling continues, and so they have to be taken very seriously. Turning the head to the affected side basically takes some of the stress off the sternocleidomastoid muscles and can relieve some symptoms. It's not like it goes away, they're just more comfortable being down to the position where the dislocation is, and that can be a finding as well. Paresthesias are also uncommon but they can happen. We talked about mechanism of injury, contact sport being, most common. MVA is also not uncommon. Atraumatic subluxations are typically from degenerative change in the joint or ligamentous laxity, as Dr. Swan was talking about before. So if you have somebody that has just an asymmetry from one side to the other, one of the first things I do is look to see if they have generalized laxity anywhere else. And I don't want to say I poo-poo it. It's something we continue to observe, but there's not much to do for it other than strengthen the muscles around it. Degenerative subluxations for older patients, 50s and plus, are not uncommon, and again, they should typically be treated with just simple observation. As far as the stability is concerned, we talked about, or I showed you the picture of all the ligaments and the disc that provides a certain level of support to that area. It should also be noted that there is a growth plate there that will not close in many patients until they're in, between 21 and 25 years old. And that can be also injured. It doesn't have to be a joint injury. It can be a growth plate injury. So for your younger patients, even if it looks like it's dislocated or subluxated, it may actually be at the growth plate where that has occurred. We talked about the ability for this to support the weight and the strength of the upper arm, but it also does provide a function as far as protection to the underlying structures, which is really quite critical, because the blood vessels and nerves that are just below the clavicle really are very easy to injure, and without having some sort of the axial skeleton protecting that, then we'd be at much higher risk for injury to that area with just simple things. As far as figuring out what's going on, once you've identified this, we usually will get what we call serendipity views. You don't have to know the data behind it, but basically it's like taking an x-ray that's facing upwards a little bit, and it gives us an opportunity to see the clavicle coming down to the sternum, and you can relatively see one higher than the other, or one posterior to the manubrium, indicating a posterior dislocation. For those that we have great concern for posterior dislocations, we'll frequently get them right into a CAT scanner, because that's going to show it the best. It does help us to, again, identify fractures, physeal fractures from frank dislocations, and can help us with our preoperative planning, because most of the posterior dislocations we're going to do something about. Not all of them, but most of them. Large prospective studies are simply not possible because of the infrequency of this, so it's hard to bring you lots of data. There are lots of case reports, there are a few meta-analyses, but nothing that really has a whole lot of science behind it. So we're left with, these ideas of Gestalt, how was it done in the past and did it work, and they're not necessarily well studied. But as a general rule, the anterior dislocations are best left alone and treated symptomatically, allow for the soft tissues to heal, and then appropriate rehabilitation, and then a return back to sport based on their functional recovery. We frequently will deal with the younger population with more unstable physeal injuries, even if they're not posteriorly, with some form of stabilization in the hopes to try and get that to be grow properly. But that's something that's still, again, an argument that's out there. Again, degenerative subluxations, which you're going to see really in your parents or in your aunts or uncles. They're going to say, hey, what about this thing here? And I've got lung cancer, or I've got something bad. Usually not. Very rare to actually have a real tumor there. It can happen, but it looks like a tumor, and in fact, it's just that subluxated area. So I'm not telling you to tell them not to worry about it at all. I mean, it's still the kind of thing that they can go see the doctor and get it checked out, but it's almost always just degenerative subluxation. As far as incidence, again, there's hard to get good studies for this, and so the epidemiology of SC pain, this is a study with 3 very large hospitals. Again, it's a European study, but over nearly a 3-year period of time, they only had 44 patients show up that had sternoclavicular pain, and of those, most of them were degenerative arthritis, and acute trauma being sort of in the middle, and tumor being the most uncommon. So that's the generalized breakdown that I think most hospitals will see. This is a CAT scan demonstrating what it can look like just from arthritis. I mean, that looks like arthritis of any other joint, but you can see how there can be a prominence there. It doesn't necessarily have to be a subluxation or dislocation. Just the osteophyte itself can demonstrate a prominence. And it's one-sided. This is showing you both sternoclavicular joints. So here's the affected side here. Excuse me, did I say that right? Yeah, Yeah, and here's the unaffected side over here. So you have to have a clinical suspicion for that. I don't think everybody that has a bump there needs to get a CAT scan, but this is a good example of what it looks like. This is what it will look like clinically with just a slight prominence, and you can get that to sometimes be a little bit more evident with just a rolling of the shoulders. Roll the shoulders forward, and you'll get a diminishment as they roll their shoulders or protract their scapula. Again, posterior dislocations, this is again a CAT scan. Here's relatively normal sternomanubrial or sternoclavicular, I don't know why I keep saying manubrium, the sternoclavicular joint, and this is the clavicle here now posterior to the sternum. And you can see its relative proximity to the mediastinal structures, your aorta, your trachea, your esophagus, and these things can easily be compressed, creating those kinds of symptoms of dysphagia, tachypnea, any of those things. So you have to have a high clinical suspicion, and these things we don't typically like to leave there because they can, even if a kid's minimally symptomatic, you can end up having an erosion of the bone through the esophagus if you don't treat it. And so in many cases we'll want to reduce that joint. So as far as the treatment, again, we talked about the degenerative and anterior subluxations most commonly are just treated with really benign neglect or observation. Certainly if you see somebody that has a mass that's changing or expanding, that may be something different. That's what I do. If I see somebody with a degenerative subluxation, I'm not going to run them through the mill unless I start to see some things that are changing and making me think that it's more of a aggressive thing than just a subluxation. For those posterior dislocations, we have to talk about open versus closed reduction. We basically grab it with a towel clamp, protract the shoulders, and pop the joint back into place. We just have to do that with a lot of care, and you have to be cognizant that those mediastinal structures could have been injured. So we typically have a vascular surgeon on call, or frankly standing right next to you when you do that, because once you decompress that, it can end up having a expanding hematoma that has to be dealt with emergently. And we do treat the posterior dislocations as emergencies. I think those kids need to be packed up and sent off to the hospital. As far as ligament reconstructions are concerned, they don't necessarily have to be done that same day. For kids that have a lot of instability or adults with a lot of instability, and particularly the athletes, to consider a ligament repair and or reconstruction. And I'm a believer that once you've torn these ligaments, they really can't be repaired. So when I go in there, I may repair structures because it's more of an acute treatment of it, but I'm still going to do some sort of a reconstructive procedure with a tendon graft to support and stabilize that. Medial clavicle excision is something I don't commonly do, especially after traumatic injury, but for those people that have the degenerative arthritis or degenerative subluxation and it's just too painful, you can cut the medial head of the clavicle out, much like we do a Mumford procedure, cutting the distal end of the clavicle out, and that works very well to decompress that joint and give them relief of their pain, get them back to sport, for example. You can do interposition arthroplasties as well. That's, in my opinion, I don't think that's really necessary. You just cut it out and it does fine. I don't want to run over, I probably am already. This is what a representation of that ligament reconstruction looks like. Basically, we're making holes, looping some tendon through there and creating a ligament out of that and tying it all together. And if there is any acute injury, we can supplement that with just repairing the structures there. The rehabilitation for this, when you do reconstructions, we tend to throw them in a figure of 8 harness to try and keep the clavicle in alignment, sling them for a while, and then it's just sort of a gradual return to activities. It does take quite a while for that ligament reconstruction to set. I'm usually keeping guys out for at least 3 months, and then, starting very slowly, soft toss, throwing, overhead stuff, kind of very gradual. Most guys are going to take about 6 months to get back to overhead activities with comfort and regularity. So in summary, it's an uncommon injury. You need to have a certain level of clinical suspicion for those posterior dislocations. We usually treat them conservatively. They usually have a fairly good recovery time, but again, it's going to be somewhat commensurate with the amount of energy that went in to cause the injury in the first place. So counseling a kid, you'll be back in 3 weeks, it's like an ankle sprain. Yeah, if you barely sprained your ankle, you might be back in 3 weeks, but if you took a bigger hit, it's going to be a longer period of time, and I kind of use that analogy for them frequently. Thanks.